Welcome to another episode of Med Madness, where we delve into key medical topics to help you ace your exams and enhance your clinical practice. Today we're focusing on the crucial stages of labour, with a particular emphasis on the second stage arrest. Understanding the normal labour progression and identifying when intervention is necessary can make all the difference in patient outcomes. Let's begin by exploring the stages of labour. The first stage of labour is divided into two phases: the latent phase and the active phase. During the latent phase, the cervix dilates slowly from 0 to 6 centimetres. This phase can vary significantly in duration among different women. Once the cervix reaches 6 centimetres, we enter the active phase. Here, cervical dilation accelerates with a normal progression of at least 1 centimetre every 2 hours. Next, let's discuss the second stage of labour. This stage spans from complete cervical dilation at 10 centimetres to the actual delivery of the baby. The progression during this stage is assessed by the descent of the fetal head through the pelvis, which is measured as the fetal station. Now let's focus on the critical concept of second stage labour arrest. This condition is defined differently for first-time mothers and those who have given birth before. For nulliparous women, second stage arrest is diagnosed when there is no fetal descent after 3 hours of pushing without an epidural or 4 hours with an epidural. For multiparous women, the threshold is 2 hours without an epidural and 3 hours with an epidural. Several factors can lead to second stage labour arrest. Cephalopelvic disproportion occurs when the fetal head cannot fit through the maternal pelvis. Fetal malposition, such as occiput posterior, where the baby's head is facing the mother's back instead of the front, can also impede progress. Inadequate contractions, defined as those producing less than 200 Montevideo units, and maternal exhaustion can further contribute to labour arrest. Certain risk factors increase the likelihood of second stage arrest. Maternal obesity, excessive weight gain during pregnancy, and diabetes mellitus are significant contributors. Managing second stage arrest requires a careful and strategic approach. Operative vaginal delivery using either vacuum or forceps assistance is often the next step to facilitate rapid delivery. If these methods are contraindicated or fail, a caesarean delivery may be necessary, especially in cases of fetal distress. Additionally, if contractions are inadequate, labour can be augmented with oxytocin to enhance contraction frequency and force. It's important to monitor the fetal station, which indicates the position of the fetal head in relation to the maternal pelvis. A lack of progress, known as labour protraction, is defined as a cervical change of less than 1 centimetre every 2 hours during the active phase. In such cases, an intrauterine pressure catheter may be used to measure contraction force and frequency to guide management. Expectant management is appropriate for normal labour progression with reassuring maternal and fetal status. It's also crucial to understand that fundal pressure, which involves applying external pressure to the upper part of the uterus, is not recommended to improve delivery rates. While epidurals can lengthen the second stage of labour, they do not cause arrest and are essential for adequate analgesia during operative vaginal delivery. Visual aids, such as a normal labour progression graph, can help illustrate these concepts. This graph shows cervical dilation over time and differentiates between the latent and active phases. It clearly indicates the normal dilation rate of at least 1 centimetre every 2 hours during the active phase. Another useful visual is an illustration of vacuum-assisted vaginal delivery, depicting the stages of vacuum application and fetal extraction. Now, let's bring these concepts to life with a real-life case study. Consider Sarah, a 28-year-old first-time mother who presented in labour at 40 weeks gestation. Her labour progressed normally during the latent phase, but after reaching 6 centimetres of dilation, her cervix dilated at a rate of 1 centimetre per hour, consistent with the active phase. However, despite adequate contractions and strong maternal efforts, Sarah's labour stalled at 8 centimetres for over 3 hours. Given her normal pre-pregnancy BMI and appropriate weight gain during pregnancy, her healthcare team suspected cephalopelvic disproportion due to fetal malposition. An intrauterine pressure catheter confirmed adequate contractions, and the decision was made to proceed with a vacuum-assisted vaginal delivery. The procedure was successful, and Sarah delivered a healthy baby boy, avoiding the need for a caesarean delivery. This case underscores the importance of recognizing normal labour progression, identifying second stage arrest, and intervening appropriately to ensure the best possible outcomes for both mother and baby. Thank you for joining us on Med Madness. Stay tuned for more episodes where we continue to explore vital medical topics. Remember, understanding these concepts not only prepares you for your exams, but also enhances your ability to provide excellent patient care.